Hello everyone, today we are talking about muscular system and I am Sannan Rehman. This is the last section of this presentation. In this section we'll talk about the clinical correlates. So this section is further divided into Poland sequence, the prune belly syndrome and the muscular dystrophy. These are the clinical correlates of the skeletal system and all the elements of the skeletal system that we discussed before. I hope you remember them and I hope you are as excited as I am for this section. So first of all, we have the Poland sequence. So as I mentioned before, partial or complete absence of a muscle is asymptomatic. However, Poland sequence is a serious defect. The disfiguring nature of defect can be problematic, especially in the females due to breast development. So, examples in the absence of muscle include the absence of palmaris longus, the absence of serratus anterior, and the absence of quadratus femoris. In either of these absences, there's neither a functional element that is absent or a developmental element that is absent. It's only just the absence. It's only the absence of a muscle. The muscle is not present. However, it is not causing any major defects. So Poland sequence is characterized by the absence of pectoralis minor. So here you can see pectoralis minor is absent. We have partial loss of the pectoralis major. So we have partial loss of pectoralis major as well. The nipple and the areola are displaced or absent. Here you can see that the displacement of nipple and areola, they may even be absent. And often digital defects like syndactyly. Syndactyly is fusion of the fingers. Here you can see how fingers have been fused or webbing of the fingers. Or brachydactyly. So brachydactyly is small fingers. The length of the fingers is decreased. This is the finger length, this is normal finger length. Let's say the finger length is decreased to this. So there may be syndactyly or brachydactyly on the affected side only. So what is Poland sequence? There are four major points in the Poland sequence. The first two are related with muscles. The absence of pectoralis minor. The pectoralis minor is completely absent. Some portion of the pectoralis major is also lost. So after the loss of pectoralis minor and major, the structure that lies upon it may be absent or displaced. What is that structure? Yes, that is nipple and the areola. They may be displaced or absent. And on the affected side, we may see digital defects like syndactyly or brachydactyly. Syndactyly was fusion or webbing of the fingers, and brachydactyly was small fingers. So this can be particularly disturbing for a female, for an adolescent female who's undergoing breast development, as it may lead to unequal symmetry and it would be a very difficult condition, hence has to be treated. So prune belly syndrome, this is partial or complete absence of the abdominal musculature. So abdominal muscles, the obliques, the transversus abdominis, the rectus abdominis, they are absent. It may be associated with urinary tract and the bladder malformations, which may include the urethral obstruction. It can cause fluid accumulation, which can lead to abdominal distension. It can also cause abdominal muscle atrophy. The remaining muscles of the abdomen may also atrophy. Here you can see the abdominal contents, the intestines can be made out through very thin skin. In this patient, it is the muscular element of the abdominal wall seems to be completely gone, and we can see there's accumulation of fluid within the abdomen, which is causing distension in this child. So muscular dystrophy, it is a group of diseases which causes progressive muscular wasting and weakness. So Duchenne's muscular dystrophy, it is an X-linked recessive trait, so it affects males more commonly. Why is that? The genetic component of male contains only a single X chromosome. If the male gets an affected X chromosome, the male is bound to express the disease. However, the genetic the genetic assembly of a female consists of two X chromosomes. If a female gets a single affected chromosome, she may be a carrier, but she may not exhibit the disease. It is caused by mutation in dystrophin gene on the X chromosome. So the culprit is the dystrophin gene, which lies on the X chromosome, and hence it leads to Duchenne's muscular dystrophy. It forms dystrophin associated protein complex, which is responsible of linking of cytoskeleton to the extracellular matrix. So the cytoskeleton, which is the skeletal framework of the cell, is not being linked to the extracellular matrix, and the body cannot function properly. So in Duchenne's and Baker's type, these are the muscle groups that are involved: the muscles of the upper limb, the muscles of the shoulder girdle and the neck, and the muscles of the lower limb and the calf region. In Emery-Dreifuss type, we have the muscles of the upper limb and the pectoral region, again the pectoral region and the upper limb, the forelimb, the hind limb, not the forelimb, and the lower parts of the lower limbs. In limb girdle type, we have the muscles of the thighs are involved, and the muscles of the shoulder girdle, the pectoral region, and the upper limbs are involved. In facioscapulohumeral type, we have the facial muscles that are involved. Then we have the muscles over the scapula, the muscles of the pectoral region, and muscles of the hind limb. So we have oculopharyngeal type. In this, we have the muscles of the eyes, the muscles of the neck, the muscle of the shoulder region, the muscles of the upper limb, the muscles of the thighs. So we talked about three important conditions: the Poland sequence, the prune belly syndrome, and the muscular dystrophy. We discussed how absence, whether it may be complete or partial, of a single muscle does not cause any major disturbances. We talked about prune belly syndrome, and we talked about the Poland sequence, and the four major components of the Poland sequence. They were the absence of pectoralis minor. Some portion of pectoralis major may also be absent. That was the second component. The third component was the displacement or absence of nipple and the areola. And the last section was, what was the last section? The last section included the digital defects on the affected side, which were either syndactyly or brachydactyly. It was a pain for a developing teenage female that might undergo breast development and may have unequal symmetry throughout the chest, and that might need cosmetic correction. Now we talked about prune belly syndrome as well. In prune belly syndrome, the anterior abdominal wall muscles were absent, as a result of which a thin skin was covering the anterior abdominal wall, and the abdominal contents, the intestines, could easily be made out. As a result of this, there might be fluid accumulation within the abdomen, and the remaining somewhat muscles which were remaining there, they might undergo atrophy, and the patient might also have abdominal distension. Then we talked about muscular dystrophy. Muscular dystrophy was a group of diseases which causes progressive muscular wasting and weakness. It was an X-linked recessive trait, so it affected the males more frequently, the cause of which I told you earlier. It was caused by, we talked about Duchenne's muscular dystrophy in particular, which was caused by a defect, a mutation rather, in the dystrophin gene, which lied on X chromosome, as a result of which the dystrophin associated protein complex could not be formed clearly, could not be formed functional dystrophin associated protein complexes could not be formed, the function of which was to link the cytoskeletal elements to the extracellular matrix, and hence the cells could not act as a unison and the body could not do certain activities. So next we have arthrogyroposis, the congenital joint contractures. We'll discuss various causes of arthrogyroposis. First of all, it can be neurological defects like motor horn cell deficiency or meningomyelocele. Next, we can have muscular abnormalities like myopathy and muscle agenesis. We can also have joint and cartilage tissue problems like synostosis and abnormal development. We can have fetal crowding and constraint like multiple births and oligohydramnios. So this was all about the clinical correlates of muscular system. This also concludes the muscular system as a whole. We talked about the embryological origins of the muscles within the human body, the various sites at which the muscles were formed, the various regions at which the muscles acted, and the clinical correlates. We saw how cardiac, smooth, and striated the skeletal muscles developed and patterned throughout the body. We saw how clinically relevant these muscle development were and how various disease conditions occurred. We also saw various clinical conditions like prune belly syndrome, arthrogyroposis, and we learned how to diagnose and to manage these conditions. I hope you found this lecture as fruitful as I did. For further lectures, for further videos, keep watching sqadia.com.